So this study, it's a mouthful of a title, but basically looking at bariatric surgery versus medical management to induce diabetes remission in diabetic patients who are obese, with BMI 30 to 35. And this is definitely research in progress, as we've just enrolled 3 patients. We just started the enrollment recently, and I can go into some of the details about that. No financial disclosure, so everyone knows about the epidemic of diabetes and obesity. Basically, the country is getting more and more obese, and the prevalence of diabetes is going up. Certainly, the vast majority of diabetics are type 2, and the vast majority of type 2 diabetics are either overweight, which is BMI over 25, or obese, which is BMI over 30. Large numbers are inadequately controlled, and complete remission is rare. And it's not a secret that as your BMI goes up, your risk of developing diabetes goes up, and those who have impaired glucose tolerance often go on to progress to type 2 diabetes. So specifically for bariatric surgery, which is weight loss surgery, the NIH criteria, so this is actually from 1991 and is still the criteria used today, although they are looking at revising these guidelines, and I think that's one of the reasons why this study is quite pertinent, is BMI over 40 or BMI over 35 with obesity-related comorbidities such as diabetes or sleep apnea or hypertension. And over 18 years old, and patients have to be overweight for at least 5 years with failed weight loss with non-surgical measures and no ongoing substance abuse. These are the basic requirements for bariatric surgery, again from the 1991 NIH consensus criteria, and insurance companies follow these guidelines. And just as an aside, because there's a little bit of confusion, the FDA recently lowered the indications for the lap band, which is one of the procedures that we do. They lowered the criteria for to BMI 30 and higher with comorbidities, but insurance has not adopted that. Just because the FDA has accepted it as an indication, these are the NIH criteria, and this is what insurance companies follow. There is one randomized study looking at bariatric surgery, the medical treatment for obese patients, who are for diabetic patients. This was done in Australia. They were obese, BMI 30 to 40, and they were randomized to the band versus medical treatment, and they had a 73% remission in the surgical group versus 13% remission in the medical group. And they found that the cost, when they did a subsequent study, was higher in the conventional group due to the medications for diabetes. Probably one of the most important bariatric surgery studies in the literature this is from New England Journal from a couple years ago, where they matched 10,000 bypass patients to 10,000 matched morbidly obese patients in Utah based on driver's license data, and found this curve. This is the control group. The blue one and the orange are the patients that had surgery. They basically found that the patients who had surgery live longer, specifically a decreased mortality from diabetes of 92%, heart disease, and even cancer. And again, probably one of the biggest things that's changed in bariatric surgery is the safety. It used to be regarded as dangerous surgery, and now with the advent of laparoscopy and centers of excellence, this study came out, for instance, in New England Journal, looking at about 5,000 patients and with a 30-day mortality of 0.3%, and a major complication rate of about 4%. And what's changed is that this American Society of Bariatric Surgery created a program called Center of Excellence, which is evidence-based standards. There's 10 requirements. Surgeons have to be trained. You have to there's a certain volume required. Like each place has to do at least 125 cases a year. They come and do a site inspection, as they did for us at Bellevue. They actually look at the toilets in the emergency room to make sure they can accommodate patients who are over 400 pounds. So it's pretty rigorous, and Medicare and insurance companies will only pay for it if it's done at a center of excellence. And as part of this center of excellence, you have to contribute to a database called BOLD, which is Bariatric Outcomes Longitudinal Database, which now has over 300,000 patients in it, and is basically going to be the largest surgical database in the country. And in this, mortality is about 0.05%. So there's clear benefits of surgery with low risk. So specifically looking at diabetes and bariatric surgery, it is indicated, as I mentioned, for type 2 diabetics whose BMI is over 35. It offers complete remission of diabetes in up to 48 to even 100% or 98%, depending on the procedure. And another interesting phenomenon is that it often occurs within days to weeks before major weight loss has occurred. So the mechanisms clearly usually are related to decreased caloric intake, and weight loss, certainly related to surgery, but there is evidence that there's a hormonal effect by excluding food from the hormonally active duodenum. And that's from a rat model, and this is one of the landmark papers that showed it, where they basically took a non-obese diabetic rat and bypassed the duodenum and found immediate improved glucose tolerance and decreased fasting glycemia independent of weight loss. And it was better than the group that had a sham laparotomy that were fed a calorie-restricted diet. And this is a really active area of research, this hormonal effect related to hormones produced in the duodenum and the proximal small intestine, but the bottom line is it's not one hormone, it's a whole cascade of hormones, and really it's not clear which hormone or hormones are involved. Certainly in humans, if you look at the remission of diabetes, this is the largest study in the literature, about 4,000 patients with diabetes undergoing bariatric surgery, showing that the percent remission, which is off medications after 2 years, with a normal A1C was about 58% with the band, up to 96% with the duodenum switch, which is a more malabsorptive procedure. So that leads us to our research question, which is, what is the most effective treatment to induce type 2 diabetes remission in obese patients? So this is obese, not morbidly obese. We're talking about BMI 30 to 35, which are currently under the guidelines for the NIH. And with the hypothesis being that bariatric surgery is more effective. And this is the flow of this pilot study we are doing, and I'll walk you through it. So basically, so let me just take a step back. So Metro Plus is one of the, is the primary insurer of Bellevue, of HHC actually, and so what we did is we reached out to them, or I reached out to the medical director basically, and asked if they would be willing to collaborate to pay for surgery in patients who are outside of the NIH criteria as part of a research study. So they agreed as part of a pilot study. So this study is for BMI 30 to 35 type 2 diabetics insured by MetroPlus only and who otherwise meet criteria for surgery.
Is MetroPlus, is it Medicaid?
It's a managed Medicaid, correct, yes. We decided to take 25 and do surgery within 6 weeks, and they would go through our usual process, which I'll get into in a minute, about which surgery they have, or they would go through a 6-month, basically it's a weight loss control where they go through intensive medical weight management, and then they would cross over after 6 months. And we can discuss the trial design about clinical equipoise and other issues that come up with that, but this is basically the trial design, and mainly for feasibility to get them through. Michelle can talk about the intensive medical weight management.
Thanks. So again, I'm Michelle McMacken, and I'm a general internist, thank you, based out of Bellevue, and I run also the Bellevue Weight Management Clinic. So I'm working together with Dr. Parikh on this study and other studies in the past. So we designed the intensive medical weight management arm of this study based on some of the most successful models published in the literature. I put some of the brief references there, but essentially it's the Look Ahead study, the Diabetes Prevention Program study, the Finnish Diabetes Prevention study, all of which essentially used very frequent contact in a group setting with a nutritionist and at times with a behavioral psychologist. And by frequent contact, usually the model was every week for a sort of an induction period of a few months, followed by bi-weekly sessions. All of these studies were very effective in inducing weight loss on the order of 5 to 10% of total body weight over the duration of the study. So that was the model we were using when we designed this, and keeping in mind the resource limitations. The plan is patients will be seen every week by a weight loss clinician who's actually a certified diabetes educator as well. So they're going to be seen every week for the first month, and they're going to be given very tailored, culturally appropriate counseling in order to help them modify their lifestyle and lose weight. So essentially going through nutrition, going through physical activity. We have pedometers for the patients. We're going to lead them through that program. After the first month, they're going to be seen every 2 weeks for the remaining 5 months of the study. So as I mentioned, there'll be goal setting and information on diet, physical activity. The weight loss clinician will be reviewing their home glucose logs, because for a lot of these patients, as many of you probably know, when they start adjusting their diet and being more physically active, their sugars tend to decrease significantly. And so if they're on medications that might contribute to that, that could be an issue if they become hypoglycemic. So that's why we want the frequent follow-up, and we will actually reduce or discontinue their medications if needed. Again, we're going to give pedometers to all the intensive medical weight management patients and guide them through a pedometer-based walking program. So we're setting as a goal 5% of body weight loss at 6 months. Now that's in keeping with the most evidence-based trials, but it's an ambitious goal. We are requiring that patients lose at least 2%, which is a much more modest goal, obviously, of their total body weight at 6 months in order to qualify to cross over to the surgery arm. And we can talk through a little bit of why we required that. I think that, yeah. So we'll come back to that topic in a little bit.
Question.
Yes.
Can you comment on your outcome measure? So
It's coming up.
It's coming up. Okay. I'll wait.
So the procedure itself, this is a schematic of the, we offer 3 procedures at Bellevue. The gastric bypass involves taking a surgical stapler and cutting the stomach to about the size of an egg, and then hooking it up to the jejunum. This is the Roux-Y gastric bypass, which is the most common bariatric procedure performed in the country, which generally delivers about 80% remission of diabetes, is the ballpark based on that meta-analysis I showed you. There's another analysis which is required, which is jejunal judge. So these are all done laparoscopically. This procedure is called the gastric band. So with the gastric bypass, the average patient who's, let's say, 100 pounds overweight would lose about 70 to 80 pounds. So about 70% of their excess weight would be lost. This is the gastric band, which involves placing a silicone band around the upper part of the stomach, so there's no cutting of the stomach, which is attached to a port which sits under the skin. And this band is adjustable, so you adjust it post-operatively to make the band tighter to restrict their appetite. So the weight loss is a little bit slower than the bypass, and the overall weight loss is a little bit lower. This is a relatively newer procedure called the sleeve gastrectomy, which is increasing in popularity, which involves cutting the stomach and removing 2/3 of it. So I figured I'd show you guys at least a video of one of these procedures. Hopefully no one gets... Are you guys okay with seeing a video?
Over lunch.
Over lunch? Where you? If anyone wants me to stop, just say it. But I figure I can't give a lecture without showing something. So this is the stomach. This is the liver. A lot of these patients have huge livers from NASH, non-alcoholic steatohepatitis. So for the sleeve gastrectomy, that's what this procedure is. We take this is an ultrasonic scalpel basically that cuts and seals, and we're dividing the attachments between the stomach and the omentum. So the gastroepiploic artery is here. We're dividing the stomach, we're mobilizing the greater curvature of the stomach basically inside the gastroepiploic. Here's the spleen. The head of the patient's up here. And we free up, this is the left crease of the diaphragm, so we have to free up all of this, basically the fundus of the stomach. The fundus is where the ghrelin, which is a hormone-regulating hormone, is produced. This is the pylorus of the stomach. And if we measure, that's about 5 centimeters, the length of that bowel grasper. And then what we do is you basically cut and divide 2/3 of the stomach. So this is the stomach totally mobilized. This is the surgical stapler that we use that has a special buttressing material on the staple line that helps prevent bleeding along the staple line. And then the next step is we essentially cut and remove 2/3 of the stomach by stapling the stomach. So the anesthesiologist passes what's called a bougie, which is an orogastric tube. That's this tube coming down. It's about a 40 French, which is about 3 point something centimeters diameter. And we basically staple along that bougie. And this is the kind of the newer technology of laparoscopy with these staplers, because it makes surgery much easier because it cuts and seals and divides. In the old days, these staplers did not divide; they only put a staple line there, and those staple lines were at risk of opening up. And so this 2/3 gastrectomy, then you remove the stomach, and we, by placing like a sterile bag inside, and we just take the stomach out, and then we basically put some sutures here to reinforce the staple line. And just to give you an idea of the capacity of this new stomach, we'll do a leak test where the anesthesiologist passes an orogastric tube, so we have the pylorus clamped, and they're inflating. This is just 60 cc's of fluid, and you can see how much it distends. So it's definitely at least a 2/3 reduction of the stomach. So, yes.
Do you ever remove fat while you're in there? I mean, why?
No.
Is that not? I know it's probably ignorant.
Well, it's funny.
but-
A lot of patients come to us thinking that we're going to do
That you're
liposuction
gonna-
as
yeah.
well, and the fact
That's
is
not
that there's
part
no
of it.
metabolic effect of removing
Remove
fat.
Okay.
And now the plastic surgeons have kind of learned, because they've done liposuction on some of these patients who then need bariatric surgery, and then their results are not as good.
Oh, interesting.
And so they actually now refer for bariatric surgery first, and then they can have their body contouring afterwards. Yeah.
I know you mentioned hormonal changes in the duodenum or the
Yeah.
duodenum, and then ghrelin levels. Do you ever test ghrelin and leptin levels after the?
It's been done, and we're actually looking at that in this study. It has been done. Basically, ghrelin, which is the hunger-regulating hormone, they did a randomized trial comparing band and sleeve, showing a decreased ghrelin with the sleeve, and it continued up to a year post-op. While with the band, it didn't change and actually increased a little bit, and this related to cutting the ghrelin-producing stomach. The leptin is a more complicated hormone, and let's just leave it at that. It's more complicated. So the inclusions for this study are basically, as I mentioned, NIH criteria, which is age over 18. They have to be type 2 diabetic, BMI 30 to 35, and insured by Metro Plus. The NIH remaining NIH criteria are as listed. So patients go through an evaluation. So these patients will go through the same evaluation process that our regular patients go through, which is they come to a monthly seminar, which is bilingual, to get the basics about these 3 procedures, because usually the patient decides what procedure they want, what's right for them. It's not us telling the patient. Some don't want a foreign body, some don't like the idea of cutting the intestine, so it's a little bit more involved than like taking out a gallbladder, for instance. The patients are really involved with this decision. Then they're evaluated by the team. The exclusion criteria, if they don't meet the NIH criteria, or they're involved with other trials, or they have significant psychiatric issues. Specifically, Michelle can talk about the outcome, and this will address the
2%.
the Scott's question, or it may address.
Right. So, just to remind everyone, this is a 6-month pilot feasibility study. So we based our decision on outcome measures on the fact that it's a very short-term study. So we made, our primary outcome measures are change in insulin resistance, and we're going to use something called the HOMA-IR, which many of you may be familiar with, to assess that. So the HOMA-IR has been validated in numerous trials. It's a well-established mechanism for determining the level of insulin resistance in an individual patient. It's subject to a few issues. The lab measurement of the insulin level, the assay is a little bit finicky depending on what lab you're using, but essentially this is the model that's used in most trials. So we're using the HOMA-IR because it's going to be very difficult, as most of you probably know, to use a glycosylated hemoglobin since we're talking about such a short-term study, and the glycosylated hemoglobin reflects 3 months worth of glucose changes. So our other outcome is full remission of diabetes, and we've defined that as that person is not on any diabetes medications, and that they actually meet the WHO criteria for not having diabetes, i.e. fasting glucose of less than 126, and they pass a 2-hour oral glucose tolerance test with a finger stick of less than 200 after 2 hours. Some of our secondary outcomes, as you can see here, we're looking at within patient changes in their weight. Obviously, we're going to be measuring waist circumference before and after, blood pressure, their A1C, and their fasting lipids. And
we're doing the hormonal assays. This is our protocol has been revised about 6 times now, but we have partnered with Fritz Francois, and we are checking these, since we're doing an OGTT anyway, we're checking these hormones and we're storing them at the CTSI lab. So that is ghrelin, leptin, GLP-1, and peptide YY. For what it's worth, these are the statistics. The nice thing we have is we have that randomized trial of bands, which were that was published in JAMA, that was very mild diabetics. They had diabetes for less than 2 years, and they had a huge difference between the surgical group and the medical group. So theoretically, we would be able to detect a difference with a small sample size. But again, this is really just more feasibility in setting up the infrastructure. What we're doing is we're lumping everything into bariatric surgery, which we expect to be somewhere between 60 and 80%, right? Banding versus bypass versus medical weight management. So you're right. That's a different question. Which surgery is better for patients with type 2 diabetes? But the point, this is all patients who had BMI over 35 that met criteria for surgery. All we're doing is we're taking kind of that whole existing framework and just applying it to a little bit.
30 to 30.
But right now, our biggest challenge is actually patient recruitment, and it's not a surprise that that's a challenge. I think if you look at the numbers of patients that have bariatric surgery nationwide and the number that are eligible, it's probably about 1 in 100 or under 1 in 100. So obviously, those same numbers would apply for patients with type 2 diabetes who are obese. So we've gone through various permutations of patient recruitment. There's no doubt that there's plenty of type 2 diabetics who are obese with MetroPlus that walk through the front door of Bellevue. The key is actually finding them. And we've gone through various strategies to find them. We started with partnering with 5 specific primary care physicians at Bellevue using their provider code. There's a separate HbA1c clinic for patients with diabetes that are not well controlled. And then we screened them on a weekly basis, identified them by BMI and type 2 diabetes, and then approached them to make sure they have MetroPlus, and then found out a lot of these patients didn't have MetroPlus or they're not sure or whatever, so we changed the strategy from that. So we also then, just to give you a quick, we originally had, for various reasons, the protocol was only patients with diabetes for under 5 years. We actually got rid of that requirement. We also originally, as part of our protocol, had group sessions and got rid of that as well because I was becoming an obstacle to recruitment because they had to recruit in blocks. We did try to partner with endocrinology, but for reasons that are, for whatever reason, we're not able to partner with them. The other problem is and endocrine has a different kind of category of diabetics. They have a lot of type 1 diabetics and the patients that are more complicated. Interestingly though, and it's not a surprise that Bellevue's a challenging place to do research, but Bellevue does have some tools that are actually quite useful. For instance, if I'm able to provide a clinic manager with 100 medical record numbers, he can run it through a data query and generate a list of which of those medical record numbers have type 2 diabetes based on about 15 different diagnosis codes, and MetroPlus, because MetroPlus has its own code in the system. And so actually I wanted to, once we got that process there, I wanted to actually screen all the clinics at Bellevue. There's over 200 clinics. But the problem is their scheduling system is a very old, 20-year-old system, and you actually have to cut and paste each screen into the Excel. It gets very complicated. Basically, it takes, for each provider template, it takes 10 minutes to cut it into Excel. So I'm working with them to actually get this better, because actually, I just met with them actually this morning about this, and apparently Siemens can run some type of report and we can do it. So the bottom line is right now we are screening 25 primary care physician templates. We just started that a couple weeks ago. And so 25 primary care physicians over the course of a week is about 200 or 300 patients. And then we clean up that list, get the MR number, give it to the clinic manager. He gives it back to us on who's got MetroPlus and type 2 diabetics. And based on that, then we look up the BMI and MySys, or just have the patient come to our clinic and have further discussion. Obviously, if you have 30 patients that are eligible, maybe 1 or 2 or maybe 3 or 4 will say they're interested, of which maybe a couple will actually enroll. The bottom line is in terms of infrastructure, getting patients through the system, we're really fine-tuning this recruitment process, because there's no question these patients are there. There are patients that are interested. It's a matter of really targeting them. And we've gone through we've discussed various strategies, including just handing out flyers to everyone that walks through the front door. Sometimes that may be easier than doing this whole screening process, but it looks like this is more targeted screening, and we're going to focus on a few high-yield clinics, particularly women's health, for instance, because women are more likely to get surgery, and then and we're also changing the patient recruitment flyer. We're getting rid of the term weight loss because a lot of patients don't view themselves as obese or BMI 30 to 35, even though they are, and focusing more on diabetes since that's actually our primary endpoint anyway. So this is actually our biggest challenge right now is the recruitment.